Okay, thank you. We're going to move into the panel discussion part of this section. So I'd like to ask the last few presenters to come on up while you all think of your great questions. And, oh, great. Yeah. We need to get the mics like going for that. Yeah. And there's. we just-
I'd like to start it on. I'd like to start out with a question for Dr. Baxter. You mentioned the physician's clinical support system for primary care. Today you have a very captive audience, and many of us are involved in medication-assisted treatment, particularly opioid treatment programs. But I'd like you to provide maybe some insight on how you see that the PCSSP may be helpful in collaborating and communicating with physicians that don't work in the addiction field. And as was revealed today, we are the problem, the physicians. We are prescribing primary care, psychiatrists, and many case specialists. So give us some insight and a little more detail about the PCSP.
Okay, well, thank you very much. That's a great question, but I want to hasten to say that it's not just for physicians. Anyone that is involved in providing care, mental health, or substance use treatment can access this. It's www.pcss-p, I think it's .org, or maybe .com, I'm sorry. But it's there. It's a group of mentors that are available to answer questions. They have what's known as a warm line where you can actually call in. You may not get a call back within a business day, but you would get a call back within what's considered a reasonable amount of time. And also you could obtain mentors in your communities. There are physicians that have volunteered to be mentors, and you can call them and really get free consultation and develop a relationship in many cases. So it's available all over the country, and I think that it's a very valuable resource that people are not aware of, and the best thing about it is that it's free.
First of all, I'd like to say very good presentations, guys. I really enjoyed your message, and so thank you very, very much. From my perspective as an administrator in the city, there is a particular problem for a number of our providers when somebody shows up at their door using benzodiazepines. And it's almost like, the vampire at dusk. Doors start shutting, people are turned away, you can't come to this program, and we have all kinds of knee-jerk reactions. I just would like to get from each of you, just your perspective in terms of how we begin to change that perspective and how do we begin to do the job that we are meant to do in terms of serving those people who show up with a number of other drugs other than opiates on board.
Well, education is key, but what we have learned, and I'm sure all of you would agree, that people sometimes don't go for education, and if it is available, they don't care. But we're going to actually have help from the federal government. These grants that are coming out from SAMHSA and as I don't need to tell you guys know how the system works better than I do, but what's going to happen is that you're going to be mandated to be able to take care of patients who are on benzodiazepines, patients that come into mental health facilities that are on medication-assisted therapy. The funding that is going to be given out is going to be tied to that ability to provide services for those people. I'm the medical director for the Division of Mental Health and Addiction Services in New Jersey, and we have actually begun writing that language into our contracts for facilities, that if a person goes into a mental health facility, whether it's a psychiatric hospital or a freestanding, if they get money from the state or from the federal government, which I'm telling you is coming, they're going to have to be able to provide these services. On the flip side of that, people that are coming into addiction treatment facilities can't be just kicked off of all of their medications. They have to be able to provide a mechanism to evaluate and then allow that person to continue on that medication. And if they don't do it, then they won't get money. So I always rather educate, but when that fails, let's legislate.
I think in our methadone clinics in Philadelphia, we have Parkside Recovery and Parkside Recovery Germantown. We're in a fortunate position that we have a large census of 1,050. Roland would say it's too large, but because of that, we're not capped. We don't turn people away because we're full. So I think it's pretty well known in Philadelphia that, what does it say? Parkside takes anyone, but it's not really true. We are pretty strict on our intake criteria, but we absolutely do not turn away people because they're positive for benzodiazepines, because that's almost everybody that comes in the door, some days. So we do not do that. But what we do want to look at is if it's individualized again. If you come in and you want to be admitted to our methadone clinic and you've overdosed 15 times at another methadone clinic because of your benzodiazepine use, and they're asking us to take you because you've utilized every service there already, then we will look a little more closely, and we will insist again that we talk to the physician that's prescribing you the benzodiazepines, or maybe even say if they're just being abused on the street and this person clearly has a problem, maybe we'll say you need to be inpatient first and then we'll take you on our methadone clinic. But we absolutely individualize it, and we don't turn anybody away just for that reason.
I would just agree with that one of the big challenges, I think, with benzodiazepines is that the drug interaction between patients who are taking methadone and benzodiazepines creates a potentially very dangerous public safety issue. And in Philadelphia, where many people use public transportation, maybe it's not as big of an issue, but I always get very nervous when people leave a clinic and have benzos and opiates in their system and then get behind the wheel of a car. And so there's this tension that exists between how do you try and meet the patient's needs in the least restrictive environment. Part of the challenge for many of us who have worked in these environments, we realize that the resources available to us are pretty limited. Many of these patients should, as Dr. Murray said, be admitted to an inpatient facility where they can have their benzodiazepines better, at least started to be managed, where they are safe and not at risk for public. I take a lot of cabs, and people who know I ran a methadone program say, "Hey, doc, does that methadone stuff work?" If I had a penny for every time I was asked that question. And the reality is that, yes, it works very well. The challenge, and I say this, for most patients, if you see and you say, that methadone's horrible, I'll pretty much guarantee you those are the patients who are also using benzos. And so, because the people who are on methadone where the program's working, they're moving on with their life. The methadone does not become a major part of their life. It's the people who have, with the benzos. And so I think if on my Christmas wish list is a streamlined ability to move patients in between levels of care, because we sometimes need to move these patients inpatient or into a secure setting where they can be evaluated. Maybe their high dose brought down to therapeutic, get involved in some other activities. So then they come get into methadone programs. Methadone programs for a long time had been free of legal liability. Lawyers now have found that we are a great gold mine to be able to have suits that end up paying off. And so it behooves us, if not from a therapeutic standpoint, from a financial and legal standpoint, to be able to really look at this issue and decide what is the best treatment for these patients. And that's probably going to involve, for many of the patients, being involved in a more contained situation, such as an inpatient unit.
I just want to add one thing, and that because I'm not going to reiterate everything that everybody has said, which I completely agree with. But the other thing that I have found is crucially important in helping to manage these patients, and particularly in patients under the age of about 30 to 35, is getting their family involved. A lot of times the family thinks that methadone, as Dr. DiMaria was just saying, is horrible. The patient's falling asleep in the chair and setting fire to the chair with their cigarette and this, that, and the other thing. They don't have a clue that the patient is abusing other substances and primarily the benzos. And when they realize that, I actually had an aha moment with a family member one time. I had the ability to move between levels of care. And I put the patient inpatient, got him off all the benzos, and required a family meeting before he came back to the outpatient setting. And his mother was so angry she wouldn't come in, but his sister came in. She goes, I knew that the methadone was a problem. I said, his methadone dose hasn't changed. She goes, then what has changed? I said, we got him off of all of the benzos he was taking. So then we got down to the nitty-gritty of what his behaviors were, what was influencing his behaviors, and how he was managing to get around all of the safeguards both the program and his family thought that we had put in place. And his sister finally looked at him, and she looked at me. She goes, Uncle Joe will be driving him every day back and forth. Because he was taking the long route to public transportation in order to go where he could get his daily necessities taken care of. And she goes, well, I guess we can take care of that, you know. But engaging the family and educating the family as to what the patient not only is doing, but how it is affecting them, their recovery, and the rest of the family, I think is really something we can't overlook.
So the question that I had is, So the question that I had, our OBGYN colleagues look towards us helping manage their patients who are pregnant and addicted. If you choose to keep a pregnant patient on benzos, knowing that they are category D and 4 of them being category X, what criteria do you need to meet and what documentations do you need to have to make sure that you will not be held liable if there's a bad outcome?
I can't see you, but I assume that you're directing that question to me. There's not a quick answer to that. I mean, the patient comes in on benzos, as I tried to explain, you know, you just can't immediately taper her because the outcome could be worse than having her stay on benzos. If she has a legitimate prescription that is being used appropriately, then it may continue. Again, it's the same old story with every pregnant woman and the issue of SSRIs. You know, there's a lot of evidence out there about SSRIs, and some of it's meaningful evidence, some of it's not so meaningful. I mean, there's a lot of confusion. But most psychiatrists will tell you that it's much more dangerous to not treat the depression than it is to use the SSRIs during pregnancy. And it's the same way with, you know, serious anxiety disorders. It's not going to be helpful to not treat the woman and then have her relapse and go from a therapeutic dose to back to a very excessive abuse dose. And so it always comes down to a balance continually of the risk versus the benefit. Obviously, everything is extremely well documented in her medical chart with all of the records, both in terms of what her use is, what the UDSs show, and what the interventions have been.
The other thing that the physician and every psychiatrist in this room, every physician in this room, every clinician, every person who practices at that level, whether you're an NP, a PA, physician, whatever, you document the discussion you have with the patient about the risks and benefits and what the alternatives are. For instance, if you've got a patient on a Schedule X for pregnancy drug, do you have the discussion with the patient about switching to something that may have better data on safety for both the patient and the fetus? Does the patient agree or disagree? And what's the discussion? And sometimes the notes get really long and involved, but you have to document that the discussion was had with the patient on the risks and benefits to both her and the unborn child. And the patient's decision was X, Y, Z.
And I just want to say one last thing about that. There's nothing that drives me more crazy than when I've documented all this in the chart and I've maybe even had a family in and discussed it and the physician notes are all there and then the counselor's treatment plan doesn't even mention that they're on benzodiazepines. So it's a multidisciplinary team approach. It's not, the doctor absolutely needs to document it, but so does the whole treatment team. Document all of your interventions and it'll stand you in good stead legally.
I would underscore that. Recently, I've been contacted by lawyers and have served as a legal expert in cases with this very same thing. And the first thing I always do is let me see the chart, because I want to see, is the program documenting what they're doing? Is there some sense of discussion of risk and benefit? What's the clinical thinking? When you get a chart that's just got a couple of scribbles in it, you're in a harder situation. When there's some sense of the clinical decision making that went on, even if it needs having patients sign indicating that you had that, that's the critical thing that is going to be. The lawsuits, they're going to come or not depending on what happens in the way the wind blows. But if you've got your chart documented, when your expert looks at it, they say, look, doctor said this, they've documented this, they documented that, and there's been a sense of treatment going on in the program, that these people are not just getting,
To me, the situation has been described. We really can't take people, most people will not be able to be brought off of benzodiazepines. We know about the drug-drug interactions with benzodiazepines and methadone, so that is also problematic. I mean, what I'm hearing is our major sort of thing to do is to document. But my question then is, how mitigating is that in court?
I'm not a lawyer and I wouldn't pretend to be able to tell you.
In your experience,
No,
you obviously have been involved in a court situation.
I'm not sure I can share some of those thoughts publicly, but and I would be happy to privately. But what I would say is that the documentation hopefully reflects the clinical thinking. The clinical thinking reflects the clinical data gathering. And so I guess, as many people suggested here, you got to do your homework. If the patient's coming in and they say they're prescribed benzos, did you do anything to figure out whether they really were or they weren't? Or did you just say, oh, they're prescribed benzos, now I can leave?
All of us need consent from the patients to even call.
Well, but then I think if the patient's unwilling to provide consent, as Dr. Kaltenbach says, then immediately it's considered a illicit use or a dirty urine, whatever word we're using today. So I think, and then you address it with the patient that way. Say, well, you may say it's prescribed, but we don't have any documentation, therefore we consider it an illicit use. I mean, you can go further. I mean, interestingly, with HIPAA being as crazy as it is right now, the pharmacists haven't learned that yet. So if you call, it's fascinating to me the data I can get out of pharmacists. And sometimes when I'm bored, which is not very often, I like to call pharmacies and say, hey, it's Dr. DeMaria, I just wanted to verify a prescription. James, John Jones is saying they're getting, alprazolam. And they say, yeah, and the pharmacists start to tell you. And the one thing I didn't say when I spoke, which I really want to underscore and hope people would would rally around is, in Pennsylvania, I'm not sure if New Jersey has that, in Pennsylvania, we are trying to get the state to open up the prescription drug monitoring database. This would be a way that any physician prescribing a controlled substance could log on and find out whether or not patients have been prescribed other controlled substances. These databases exist in other states, and they basically require anyone who dispenses a controlled substance to log into this statewide system, the patient information, the drug dispense, the amount. And so providers who are registered with the system can then go access that, and you can look it up. So when you're ready to write your script for methadone in a methadone program, buprenorphine in an outpatient setting, Klonopin in your outpatient mental health setting, whatever you're doing, you go log in and you get a sense. You got what the patient told you, you got what the database shows, and hopefully you say it gives you more data. One of the challenges we may face, even if we have such a database, is will the providers access it? So, you can have it, but do people access it? And so that will be another hurdle that we'll have to go through. But I think this is a tool that can be helpful. So that, again, the issue with the chart is if you document it and it shows you've tried to collect the data, you've exercised some clinical judgment, I think the chances of person having a successful case becomes much smaller. The opposing side will always be able to hire someone to say how horrible you are and how horrible practice of medicine you conduct.
The other thing that I think really needs to be documented, because I completely agree, you can always bring a lawsuit, whether or not it's successful is the issue. But you need to have the discussion that the patient was informed and demonstrated some understanding that what they were doing may or may not be harmful to them or to others. For instance, if a patient is perfectly stable on a stable dose of benzos and on a stable dose of methadone, neither one of which are problematic, and you have documented that you've had the discussion with the patient about responsible care for their medications and stuff like that, you're probably going to be okay. If your patient's coming in completely intoxicated and stumbling down the hallway to get to the window, and you go ahead and medicate them, and nobody assesses them, you're probably not going to be okay. But I think that's where both the documentation and that the documentation has to reflect the clinical reality. Some patients are going to get well at a different rate than other patients. Some patients are not going to get well at all. And I absolutely love the patient who comes in, gives one positive urine on intake and never again. We would all love to have all of our patients be that patient. Unfortunately, that's not the population we deal with. But you have to have your chart and your multidisciplinary program documenting that this is the recognized problem. The patient recognizes it as an issue. The patient has been informed of the safety issues here. And there's only most people will recognize that there's only so much you can do with some people.
And I want to be the fifth one to say that documentation is the key. Like Peter, I've been involved, and if you are practicing what the standard is, and if you write down simply that you had the discussion and you made a recommendation, that will cover you. I'm not a lawyer either, but I've been involved in a lot of these cases. And the other thing is that when this network becomes available to physicians, that's then going to become part of the standard of care. Because some lawyer I can hear right now saying, well, doctor, did you log in to the network to check to see if this patient was getting, and if you say what network, you're going to be in trouble.
Dr. McNicholas, you talked about benzodiazepine maintenance, and Dr. Murray, you talked about patients who need benzos, and Dr. DeMarie, you talked about 7 years, patients who have been on them for 7 years probably can't get off of them. I have the somewhat unique experience in running an inpatient methadone maintenance program. We are referred to and refer out to methadone programs throughout the region, Philadelphia and the outlying counties, including Lehigh County and Northampton. And I see that programs take very different tacks toward the benzo issue. Some programs have a complete zero tolerance policy. Some programs who have a zero tolerance policy react to benzodiazepine use by sharply cutting the dosage. I'm interested in some of your experiences with that because we only see the ones where it fails. I don't know if that succeeds in some cases, but what we see is patients whose dose is cut in half or cut drastically, and they use more benzos and they use more opiates to compensate. My own experience over 13 years has been a drift toward a zero tolerance policy, at least in the inpatient context. It's just been my personal experience that I was more tolerant earlier on, and the times that I have prescribed benzos in my program, I've regretted it 80 or 90% of the time. And conversely, I've been surprised at some patients who adamantly and absolutely needed benzos for their severe, unremitting anxiety, and it was the only thing that ever worked for them, and they had to have it, and it was not an option, and we usually detox with phenobarbital in 7 to 10 days. And by the end of the stay of some of these patients, they were able to say they were wrong, that they feel better, and they didn't think they'd ever get this monkey off their back. So it's really a way of conceptualization. When someone feels they need benzodiazepines, is that the need analogous to an addict needing their drug? Or is that an anxiety disorder needing relief from the anxiety medication? And I can't tell for the most part, most times. But I'm interested in your thoughts on the zero tolerance versus some tolerance, because I think also, if I were one of my patients, I'd be hearing some of your comments, especially, Dr. Murray, when, the patient needs benzos. When I did allow some benzo prescription, miraculously, within days, a number of other patients were coming to me with the same kinds of stories and the same kinds of words, and it's a community of addicts and a community of methadone patients, and I would hear, oh, that's the clinic I could go toward because they'll let me get on benzos if I can play it right. So I'm interested in your thoughts on that.
Well, since you mentioned my name, I'll go first. Because we're all ready to go with this one. I didn't mean to give the impression that I approved benzodiazepine use in an outpatient setting. And while we do not have a zero tolerance, I actually had a counselor came up to me and said, we have a zero tolerance for benzos, right? And I'm like, well, not quite. Because if you have a zero tolerance, you're taking away that individual treatment. And when I tell you that in our methadone clinics, which are very large, I think there's a handful of people that we allow to take benzodiazepines. There's very few people that have been on them for many, many years. They're not coming in impaired. They're not bouncing off the walls. They're not missing days of treatment. They're coming to their groups. And I or one of the program physicians has a very well documented note in the chart to say that I've spoken to their psychiatrist, that they've tried other modalities. We've got one guy that was wounded in Afghanistan that has PTSD, and they've tried everything with him, and it just doesn't work. So he's on a low dose of Klonopin. And we coordinate with this psychiatrist. The psychiatrist knows he's on methadone, but it's very few. There's a handful of people. But to say no, nobody can take them, that wouldn't be good medical care. But to say that most of the people that are taking them are either abusing them or depending on them, I don't mean that they need them. So we're pretty strict with that. We don't believe in slashing doses in half, but we see them frequently. We have a lot of different doctors, and we make sure we have regular follow-up with the people that are using benzodiazepines.
I think it's interesting because where you have moved toward a more zero tolerance policy, I have moved away from a zero tolerance policy. I used to be much more no, never, never, never. And I have learned to never say never. And would I like for all of my patients to not be using benzos? Absolutely. Is that realistic for some of my patients? Probably not. Just as it is not realistic to think that all of my patients are ever going to taper off of methadone, there are neurochemical and neurobiological changes that occur with opiates and with benzos, and I'm not sure that we can get some of these patients off. Can we get them down to the lowest possible stable dose in which they are not abusing or misusing the medication? That's a goal with some patients. Would I say that my goal for all patients is eventually off? Yeah. Do I think I'm ever going to get there with some patients? No. And I think that you have to look at the abuse misuse versus therapeutic use in a patient who's struggling and compliant and doing everything that that patient can to help you move along the track. But I can't see, as I say, I think our pathways have been interesting because I used to be much more zero tolerance than I am now.
The other thing, I'm familiar with your treatment setting, and I think the critical point that you make that's important for us to be aware of is you're working with patients in a secure setting in an inpatient facility. And I think the question that goes through, the question I would ask is, if you did a follow-up study of the patients you took off the benzos maybe 6 months, a year after they're discharged, how many of them would still be benzo-free? The research would suggest that a very small percentage would be. So I think the key here is in a structured setting where there's a lot of support, the ability to get people off is higher. And I think you should get, and you should try that. But I think we also want to keep things, keep our minds open. One thing that I noticed when I was working at Family Center in their residential programs, we would stabilize patient and outpatient, and then they would go to the residential facility, and then we'd get reports back that the women were nodding off in groups. And we frequently found that when the women went into the residential facility, that we really needed to decrease their dose of methadone because they didn't need as much. I mean, people come up with different ways of saying this, but I think when you're in a structured setting where there's a lot of support, you know, the need for these medicines may be less. And we also found, because I don't know if you ever studied it, I was a study I was going to try and do, but when women leave the residential program, frequently their doses of methadone needed to go up. So I think the most important thing is individualizing treatment. I think everyone should try to get off benzos. And I think that frequently having someone go inpatient is a great way to do it because you can put a lot of things in place. But I think we also want to leave room that there are going to be some patients that, despite our efforts, may not work.
And I just want to come back to that thing about zero tolerance. That puts you at risk for some legal liability. And you can imagine that well, there has been cases where individuals who have been taken off of medications by a physician who later had an untoward event. When these attorneys show up, they'll say, well, why did you take the person off? And if you say zero tolerance, that's not going to go over very well. So I'm just restating some of these risks that physicians have when they prescribe these medications.
The other thing that I really think we need to take into account here is the patient better off in treatment appropriately using a medication, even if it's a benzo, than they are out of treatment? And that's not something that we've actually stated here. And I'm not a big harm reductionist fan, but most of my patients I mean a strict harm reductionist. Most of my patients do better in treatment than they do out of it. And if we're going to toss people out of treatment when they're making a legitimate effort to improve in another aspect of their addictive disease, I kind of have a problem with that.
My question is, as a counselor at a methadone program, we deal with a lot of people that use benzos prescribed and illicitly. And for that patient that is abusing them and it's dangerous to their health and their well-being, and we tried every intervention and we counseling and educating, and we determine that the need is for them to go into inpatient, and then we try to get them into inpatient, and that doesn't happen. There's nowhere for us to send them, or they don't get accepted. As counselors, what are we supposed to do to help these patients when inpatient is just not happening. That's not an option.
I'm sorry that there isn't an answer for you today, but as I mentioned earlier, those types of things are being addressed on the federal level and will trickle down with the state block grants. And that kind of discrimination cannot continue to occur. If we have small amounts of monies that are available for mental health and substance use treatment, which is the whole idea in terms of bringing mental health and substance abuse treatment together, that the pot is smaller and everybody is going to have to address all of the issues. So although that's going on now, I suspect that it will not be going on into the future for.
Well, it's not going on now. I think that the issue for me, and I want to stress this very, clearly, in Philadelphia, I've been personally very proud of the fact that we've been able to offer maintenancing on every level of care except for a halfway house, and we're working on that now. The reality is that how it's the communication, the sending and receiving of the message. If you have someone who is not functioning or not responding well on an outpatient basis and meets criteria to go into a residential level of care, and we have providers in this room who are providing residential treatment with medication maintenance, we do have that here in Philadelphia. Now the question is that how are we communicating that to the payers of the service, and how are they in turn hearing that message? And if you are having a problem getting someone into a higher level of care who needs it, then I would suggest that you contact, first of all, if it's here in Philadelphia, CBH, BHSI, or my office.
Thanks. Okay, well, we've come to lunchtime. Can we have another round of applause for our presenters during this? We're going to go ahead and get started. Before we proceed back into the regular agenda, we're going to enjoy a few words from Omishade Ali, who is the Deputy Commissioner of DBHIDS. We've asked her to share a few words on medication-assisted treatment recovery and system transformation. Shade Ali.
Can I have some? Oh, thank you. Good afternoon, everyone. I'm so glad to see people stayed. You know, a lot of times people eat and run, but obviously you're hearing something, you're getting something from this conference. I was not planning on speaking, but I was asked to, because I had a statement that I wanted to make to the panel, and I was asked to hold that until this afternoon so we can kind of come back and summarize what we heard this morning. I heard a lot of wonderful things. I want to share with you, especially those of you who may be new in the field, who may wonder whether or not there's any hope. I want to share with you that next Tuesday, the 14th of February, we'll mark the anniversary of 42 years since the last time I filled a syringe with heroin and cocaine. But I didn't tell you to get a clap. I told you that to let you know, for those of you, especially those of you new in the field, that people do go on and get full citizenship and go on with their lives. There is life past addiction to these chemicals that people are using. I also want to bring you back to the storyteller this morning. And I don't know how many of you heard her talk about the trauma, heard her talk about the PTSD. And I've been in the field as long as I've been in recovery. And I can tell you that in the field of alcohol and other drug treatment, the vast majority of people we see have some type of trauma history. We should not wonder why our door revolves over and over and over again if we're not looking at that history. Because if we're just looking myopically at the alcohol or other drug, it's like giving an aspirin for a brain tumor. We need to be able to diagnose and to be able to either provide care or send people for care for trauma. Because people, most of the people that we're seeing are medicating something. So if we don't identify those things and move on with that, we should just expect the door to revolve. Those of you who are not from Philadelphia, and I hope everybody here in this room has heard about what Philadelphia is doing. And you heard that Philadelphia is a national leader in transformation of services away from a passive recipient expert model to one that's collaborative. And this is where we're going with our system. I heard a lot of talk about lawsuits and people being taken to court. But if we have the person receiving services as part of the multidisciplinary team, novel idea, right? I'm going to tell you, I'm going to take a page from the mental health advocates, nothing about us without us. The days of us just discussing people and making plans for people should be over. If people receive a plan that they are the primary author of and that's relevant to them, because we're not dealing with homogeneity here especially in Philadelphia. We're dealing with culture in all of its beauty, not only nationality and ethnicity, but also faith and spirituality, sexual orientation, gender identity. All of those beautiful things that make people unique. And if we as providers really listen when people tell us who they are, I can guarantee you, your staff will feel differently about their work. The people who are coming to you for services will feel differently about the people who are providing them, and your outcomes are going to improve. I want to make sure I have said everything. And I heard family. Family is ultimately important. We need to be able to empower the family. And family, not necessarily blood. Family that's self-defined by the person receiving care. And bring everybody in together, the faith leader, the pastor, the rabbi, the priest, the imam, into this care, into this, because what we do is hard, is very difficult. So I thank you for your attention. I thank you for your work that you do, because without you, we can't get it done. But I ask you, when you leave here, please think differently about the people who are coming for services. As much as possible, try to provide care you should provide care that's directed by them and the people who care about them. And I guarantee you, you'll feel differently about your work, and at the end of the day, outcomes will improve, and people will go on with their lives. And that's really what it's all about. Thank you so much.
Thank you. All right, I just want to say a couple words I forgot to say right after lunch. Don't forget about your evaluation forms. Please reflect and provide your feedback. We do take it seriously. And also, if you have any questions about the CEU forms, please see Christine Pond. I was told that maybe the CME form or one of the forms some of them might have been incomplete, so just make sure you have a complete form before you leave.